Hello everyone. In this lecture, I am going to be covering what we call information or measurement bias. As a reminder, please make sure to submit your quiz that is due tonight by 9 p.m. So far, we've talked about error in epidemiologic studies. We've talked about random error, and then we have spent some time more recently talking about systematic error. As you remember, we covered confounding earlier on in the quarter. Last week, we specifically focused on selection bias, where we get biased results due to the way that we recruit people into our study or retain people in our sample. Today, we're going to be talking specifically about measurement error and how that results in bias in studies as well. So you all remember that confounding is the distortion of that measure of association between an exposure and an outcome because of the presence of some third variable that meets this specific criteria. One of the big things about confounding is that we can adjust for it in the analysis phase of our study, assuming that we have adequate information on that potential confounder. We also talked about selection bias, where you get biased results due to the way that you've recruited people into your study or retained people in your study. And remember, we have some target population in which we are trying to sample from, and we're trying to create a random sample that's representative of that target population. But sometimes the people that we select into those studies distorts that measure of association that we're calculating. So you might be thinking, I've learned about confounding and I've learned about selection bias in 318, so I set up the perfect study, and I don't think there's any confounding or any selection bias in my study. I want to study the association between adherence to Lipitor and heart attack. Lipitor is a medication that people take for their heart, and so I want to see if there's an association between taking Lipitor and having a heart attack. I conduct the perfect case control founding, and I say there's no the case control study, there's no confounding or selection bias, so what could go wrong? Well, let's take a look at an example. So let's say that I conduct this study and I found an odds ratio of 0.94, which is almost 1. However, the true odds ratio is actually 0.48. Without bias, the true odds ratio means that taking Lipitor, adhering to this Lipitor medication, is going to greatly reduce my risk of having a heart attack, right? So why am I seeing an observed odds ratio that is so close to 1? What on earth happened? Well, if you look at these numbers, what you see is that the number of people in these categories looks different for my true versus the people up here. What exactly happened? I misclassified the exposure status of some of my study participants. Now, how could you misclassify some of the exposure status of the people in your study? Well, the way that we measure variables is subject to error. And so how we measure medication adherence, there's a lot of different ways that we measure medication adherence, and some ways are better than others. So, for example, this slide provides a number of ways that we measure medication adherence. A provider's assessment of adherence is probably one of the most prone to misclassification, while there's others that are less prone to misclassification. So for example, direct observation of medication ingestion, where someone is actually being observed taking that medication, that's going to be a lot less prone to misclassifying people versus this provider's assessment of adherence. So errors in measurement are kind of just a fact of life. They're going to happen. They can happen when you're measuring the exposure, when you're measuring the outcome or disease variable, as well as covariates, for example, potential confounders in your study. This leads to what we call information bias, and you can have non-differential misclassification or you can have differential misclassification. And we're going to talk about these. So information or measurement bias is a bias in an estimate arising from measurement errors. It is a distortion in the measure of effect caused by a lack of accurate measurements of the exposure or the outcome variable. A defining feature of information bias is that it occurs at the stage of data collection. It is the misclassification of the exposure or outcome variable, which is the main source of error, and this in turn has the potential to bias the effect estimate. Now remember, our measures of association we're calculating that we've been talking about are things like an odds ratio or relative risk. Those are fractions. So if you move people around and you misclassify them according to the variable, that is going to distort your measure of association that you calculate in your study. Information bias results from kind of two main things that happen. So you can have imperfect definitions of your study variables. You could also have flawed data collection procedures. We're going to talk about a few sources of information bias. There are so many different sources of information bias out there. We could spend a whole quarter covering these, but for this class, we're going to focus on some of these common ones that we see in epidemiological studies. The first one we're going to start off with is what we call recall bias, and this is probably something you've heard of before and a term that you've probably used as well. Recall bias is inaccurate recall of past exposures that results in the misclassification of past exposures. It results in what we call differential misclassification, and this is important. In a case control study, it is the increased likelihood that those with the outcome will recall and report exposures compared to those without the outcome. So you're going to get a situation where there's an increased likelihood that those with the outcome might recall that past exposure, and that recall is going to look different across your cases and your controls. We could also get recall bias from underreporting of exposures in the control group rather than overreporting in the case group. It could also be possible that the cases underreport their past exposure. This is the most often cited type of exposure identification bias. It's particularly a concern in retrospective studies, so studies where you are looking back in time. And remember, we have essentially two study designs where we look back in time. That is that case control or that retrospective cohort studies. But we don't always know, exactly how that over-underreporting will happen. The important thing to know is that over-underreporting is going to happen differently across your cases and your controls, or the two groups in your study, I should say. So let's talk about an example. Mothers of children with birth defects are likely to remember drugs they took during pregnancy differently than mothers of children without birth defects. Mothers of the affected infants are likely to have thought about their drug use and other exposures during pregnancy to a much greater extent than the mothers of children without birth defects. So, even if both groups had exactly the same exposures, the participants in the cases, they may report the exposure more often than the controls. So if you're looking at this 2x2 table, you might get a situation where your cases are going to over-report being in this cell here versus that past recall of those controls. The cases have really had some time to kind of think about why they had that outcome, and so there might be issues in reporting, or I should say recalling that past exposure. So how do you prevent, or I should say minimize, recall bias? There's a number of things that we can do. So the first one is you want to use a control group that has a different disease, and you want to make sure that disease is unrelated to the disease under study. If you remember, we talked about a case control study that a group presented where they looked at individuals who had a lung cancer diagnosis, and they compared them to controls that had other diagnoses in that data set. And so the reason they didn't want to compare cases to controls that had absolutely no disease, that were disease-free, is because you want to try and prevent this recall bias from happening. You don't want to compare cases to people with a disease to a control group that's perfectly healthy, because you might set yourself up for a situation where the recall of that past exposure is going to differ across those groups. You can also use questionnaires that are carefully constructed in order to maximize accuracy and completeness. You want to make sure you're asking specific questions. For socially sensitive questions such as alcohol and drug use or sexual behaviors, you can use a self-administered questionnaire instead of the interviewer conducting the survey. And if possible, you want to assess past exposures from biomarkers or pre-existing records. If you can go back and confirm things with biomarkers or some sort of pre-existing record, that is going to help ensure that the classification is appropriate for those exposure levels. Respondent bias is another source of information bias. This is when the ascertainment of the outcome of interest may be biased when information on the outcome is obtained by participant response. So this is when information is obtained by participant response on events in which it is difficult to obtain objective information. So things like migraines or depression can be very difficult to obtain objective information on those. Oftentimes we're asking people to describe their migraine, and a lot of that information is very subjective. So having an actual migraine, if you're trying to classify people according to that status of actually having a clinical migraine versus not having a clinical migraine, it might be difficult to categorize those people accurately. So how do we try and reduce the misclassification from respondent bias? You can confirm the exposure outcome by more objective means. So maybe looking at like information in a hospital chart or medical information that's been documented somewhere versus that person's subjective opinion on their disease or their symptoms. You also want to obtain detailed information not only on the presence versus the absence of events, but you also want to collect information on related symptoms that might be part of the bigger diagnostic constellation. You can use standardized questionnaires and symptom scales to really help you kind of piece together the diagnosis of that individual. Another source of information bias is prevarication or lying bias. This occurs when participants have ulterior motives for answering a question. A subject may subconsciously feel the need to provide answers pleasing to the interviewer or study coordinator. So study participants might over or underestimate outcomes because of knowledge of the kind of treatment that they had received. So they might over or underestimate a variable. Subjects may also feel that there is some secondary gain from consciously misreporting their clinical status. So, for example, surveys of individuals who have drinking disorders or members of religious groups that disallow alcohol may yield false responses. People may not be totally forthcoming with their status, specifically because there's some sort of secondary gain or some sort of issue that they're worried about. So to prevent prevarication or lying bias, one of the things that we can do is confirm with past medical records. So look at their medical records and see if there is a history of drinking disorder for that person. You can also make sure to blind people so that in this kind of second this bullet point right here in terms of those study subjects over or underestimating outcomes because they have knowledge of the kind of treatment they received. You want to make sure that your participants are blinded in your study, right? And so you want to make sure they're unaware so they can't over or underestimate outcomes or their status because they have that knowledge. There's also what we refer to as interviewer bias as well as observer bias. Interviewer bias is usually related to the exposure variable, while observer bias is usually related to the outcome variable. But in general, it is a bias that results from the interviewer or the observer collecting the information. In this kind of bias, there are systematic differences in soliciting, recording, or interpreting information on the exposure, that would be interviewer bias, or the outcome, which would be observer bias. We typically see interviewer bias in case control studies because you're, again, going and classifying people according to some other past exposure, or the outcome where someone is observing in some sort of longitudinal study, like a cohort study or a clinical trial. They're observing that outcome and that gets misclassified because of that observer who's documenting that outcome status. This may happen when trying to clarify questions and not following the study protocol, or when the interviewer is not blinded. So if that interviewer has information on the status of the other variable, they may misclassify people because they have that information. It also occurs when data collected by the review of medical records, if the reviewer interprets or records information differently for one group, or if the reviewer searches for information more diligently for one group. Observer bias is more frequently an issue with what we call soft or subjective outcomes. So for example, pain is a very subjective outcome that is really based on the experience of that individual versus a hard outcome, for example, death. It's kind of difficult to misclassify death. It either happens or it doesn't versus something like pain, which is very subjective. This also happens when a person who provides a treatment also evaluates the outcome at the end of the study. So if the person who provided that treatment is then going and collecting data on that outcome variable, they have knowledge of that treatment, right? And they may misclassify people because that knowledge that they have and assume that someone has a specific outcome status because of that initial treatment. So how do we minimize interviewer and observer bias? You want to make sure that you are blinding your interviewers and the people collecting the data regarding the exposure or the health outcome. You want to develop well-standardized data collection protocols and make sure people are following them. You want to train interviewers to obtain data in a very standardized manner. You don't want people deviating from whatever that standard manner is, or else there's a possibility that that interviewer could misclassify the exposure or that observer could misclassify the outcome. You should also seek the same information about an exposure from two different sources. So maybe, you're asking that person to report something, but then you're going back to medical records and you're confirming. You can also use two observers to perform diagnostic classification of the outcome. Having more than one person observe that classification of the outcome can help reduce the chance that you're getting this observer bias in your study. There's also what we call detection or medical surveillance bias. This is when the exposure groups differ systematically in terms of the measurement or diagnosis of the outcome. This often happens when the exposure is a medical condition and medical records are used to assess the outcome measure. So when subjects in one exposure group are more likely to have the study outcome detected because they received increased surveillance, screening, or testing as a result of having some other medical condition for which they were being followed. So I've got an example here. People who are obese are more likely to undergo medical examinations, blood tests, and imaging studies than people who are not obese. And this can introduce detection or medical surveillance bias. If obese subjects were being compared to non-obese subjects for the risk of certain cancers, early cancers would be more likely to be found in the obese group, causing an overestimate of the true association. If that group who is obese is getting medical care, is being screened for different things at a higher rate compared to people who are not obese, you're more likely to find the presence of something like a cancer in that group that is undergoing that clinical care, those checkups on a more frequent basis versus another group that is not. So there are several things we can do to try and reduce the impact of detection bias. So this bias is primarily an issue in cohort studies. It can occur if the exposed individuals undergo a more thorough examination than the unexposed individuals. It can also be an issue in case control studies, but we're not going to get into that in this class. What you can do is to assess the outcome systematically, regardless of their exposure status. You can gather information on the frequency, intensity, and quality of medical care received by study participants. So you can essentially look to see if there's a difference across those. This bias might be an issue in your study. Selecting an exposed group that receives a similar degree of scrutiny as the exposed group. You want to make sure that both of the groups in your study don't have some difference in the way that they're monitored or that follow-up is taking place. So those are some of the different examples or specific sources of information bias that we see. Now I want to get into how exactly information bias can affect our results. So information bias can result in what we call differential misclassification or non-differential misclassification. Misclassification in general is when an individual is miscategorized into the wrong exposure or disease status. So in truth, they are a specific exposure or disease status, but they get incorrectly placed into the wrong category. So when we're thinking about non-differential misclassification, the frequency of errors is equal in the two groups being compared. This is non-differential misclassification. So that frequency of errors should be equal in the two groups being compared. Misclassification of a dichotomous exposure occurs when errors in classification occur to the same degree regardless of the outcome. More specifically, that misclassification of that exposure should happen with the same frequency across the cases or controls, across those two groups of study in your study. On this slide, I have an example. A case control study was conducted to examine the association between a high-fat diet and coronary artery disease. Subjects with heart disease and controls without heart disease were asked to complete questionnaires about their dietary habits in order to categorize them as having diets with high fat content or not. It is difficult to assess dietary fat content accurately from questionnaires, so it's not surprising if there were errors in classifying the exposure status of those individuals. However, it is likely in this scenario that misclassification would occur with more or less equal frequency regardless of the eventual disease status. So that misclassification of that dietary fat content, that misclassification is going to happen equally across people with the disease and people without the disease. This is non-differential misclassification. So what are some example mechanisms? Well, there might be equally inaccurate memory of exposure in both groups, where both groups have a difficult time remembering something in the past, remembering that exposure status that's happened in the past. Recording and coding errors in records and databases, that might happen equally across your two groups in your study. Using surrogate measures of exposure. So surrogate measure example would be using prescriptions for antihypertensive medications as an indication that the patient filled the prescription and actually took it regularly. That's often inaccurate. So using some sort of measure, surrogate measure that is measuring some sort of exposure or variable of interest in your study. If that surrogate measure is kind of off, you would expect that that misclassification would happen equally across the two groups in your study. There's also non-specific or broad definitions of the exposure or outcome can result in non-differential misclassification. So let's say you're studying the effects of environmental tobacco smoke exposure, and you're asking whether a subject's spouse smokes. That will not capture, the where, the when, and how often they smoke in the subject's presence or the subject's exposure to other sources of environmental tobacco smoke, such as the workplace. This would be a very broad definition, or maybe a non-specific definition of the exposure or outcome. Even if that misclassification happened, you would assume that it would happen equally across the groups, the two comparison groups in your study. If you have non-differential misclassification in your study, in general, what it is going to do, it is going to cause you to underestimate the effect. More specifically, it's going to take that relative risk, that odds ratio, and it is going to push it closer to the null. So that biased measure is going to be closer to the null compared to whatever that true value is. Differential misclassification is different. This is when the frequency of errors is not equal in the two groups that are being compared. When misclassification of the exposure is not equal between subjects that have or do not have the health outcome, when misclassification of the health outcome is not equal between exposed and unexposed subjects, when data is more accurate in one of the comparison groups. Now remember, when we're talking about non-differential misclassification, what we said is that for it to be non-differential, the misclassification of the variable has to be the same across your two groups in your study, right? So if you've got an issue recalling something, if it's non-differential misclassification, that issue recalling some past exposure, that has to be the same across your cases and your controls. When we're talking about differential misclassification, what we're saying is the misclassification of that exposure variable, that is happening differentially. It's happening to a different degree across your cases and your controls. Or you're misclassifying that outcome variable differently across your exposed and your unexposed. So this is happening when that misclassification is taking place unequally across your comparison groups. So here's an example. A case control study was conducted to determine whether maternal use of antidepressant medications during pregnancy is associated with an increased risk of congenital defects in offspring. The use of antidepressants during pregnancy was determined by interviewing mothers of children with congenital heart defects and mothers of normal children. Mothers who gave birth to a child with a congenital defect are likely to have repeatedly considered whether the defect was caused by something that she took during pregnancy, while mothers of normal children are unlikely to have spent time thinking about that, trying to recall their use of medications during pregnancy. As a result, the exposure distribution might be underestimated in the controls. If you think about that 2x2 table, that first cell on the upper left side, those exposed cases, the likelihood of being in that cell is going to be much higher in this case because those moms who have the outcome of interest they might be more likely to report being exposed, being misclassified according to that exposure status compared to the controls in that study, the moms who did not have a child with that outcome variable. So in this case, the misclassification of that exposure variable is happening differently across our cases compared to our controls. This is differential misclassification. Now, there are some specific example mechanisms that we've talked about that result in differential misclassification. Remember, we talked about recall bias, where essentially the recall of some past exposure, that ability to recall accurately is going to differ between the cases and the controls. So in our last example, we talked about how mothers who had a child with a birth defect may kind of over-report medication use during pregnancy because they've had time to really sit and think about it, compared to controls who may not recall that past exposure. Another example we talked about was interviewer bias, where the interviewer who is collecting information on that exposure is potentially misclassifying people, but that misclassification of that exposure is going to differ across those with the disease and those without the disease. It is differential. There's also medical surveillance bias, where you have differences in things like the frequency or the quality of care that's received. And those people who are getting more frequent care, better quality care, those people are going to be more likely to have something detected in them because they're being watched so closely compared to the other group in the study. So that is going to result in differential misclassification because it's going to happen differently across the two groups in the study. So what is the effect of differential misclassification? So remember, non-differential misclassification is going to, in general, bias our results closer to the null. It's going to push us closer to that null value. In contrast, differential misclassification is a bit more unpredictable. Differential misclassification can bias our results toward or away from the null. That direction is unpredictable. And so when this happens, you don't always know which way your results are potentially biased. Are they biased closer to the null, or are they biased further away from the null? So as I mentioned, differential misclassification can push us closer to the null or away from the null. So remember, my 1 is my null hypothesis. Because of this differential misclassification, I can observe a relative risk that is much closer to the null versus the truth, or I can observe a relative risk that's much further away from the null. That's overestimating the association between my variables of interest. Again, we really don't know always which way this is going to happen, but that's kind of the thing with with differential misclassification, is that it can really bias your results in a way that is unpredictable compared to non-differential misclassification, in which that is a little more predictable. So in summary, systematic bias or systematic error can happen as a result of the way that we measure our variables of interest in our studies. So we essentially can have bias from confounding, from that third variable that exists that meets that criteria that can distort our measure of association. We can have selection bias that can distort that measure of association, or we can have information bias that can distort that measure of association as well. Information bias is a distortion in the measure of association that is caused by a lack of accurate measurements. You are misclassifying people's status because of the way that you're measuring the variables in your study. Information bias can be minimized through some of the strategies that we talked about. So it's important to know those strategies and how to prevent, or I should say, minimize information bias in research studies. And you should be thinking about, when you read research studies, did the author do the things that they should have done to minimize information bias in this study? Or is it possible that the study is just riddled with information bias and the results are not good? Information bias results in both non-differential and differential misclassification. And depending on which type of misclassification you have, one, non-differential, is going to push your results closer to the null, while differential misclassification could push your results either way, and you don't always know which direction that is.